Now we'll see the last topic, that is heme degradation and jaundice. Specific learning objectives are, at the end of the lecture, students should be able to describe bilirubin metabolism, explain the relevance of plasma bilirubin and estimation of different fractions, and enumerate the different causes and types of jaundice and differential diagnosis by laboratory tests. First, to understand the jaundice. What is jaundice basically? Jaundice is a clinical condition where there is a yellowish discoloration of conjunctiva sclera and mucous membrane. And to understand the different types of jaundice, we must be able to understand the degradation of hemoglobin. So, hemoglobin, when the senescent RBCs, when the RBCs get senescent, these will be taken up by the macrophages and of the liver, bone marrow and spleen, and so there will be degradation. There will be first lysis of the RBCs, and so there will be degradation of the hemoglobin, and this hemoglobin is degraded into heme. 80% is from senescent RBCs and 20% is from immature RBCs as well as from myoglobin and cytochromes. While globin, which is released, it is also degraded, and it is degraded to amino acids, and amino acids are reutilized. So 85% is from old RBCs and 15% from other heme proteins, that is myoglobin and cytochromes. Globin, amino acids are released and reutilized. Heme, iron is released in the ferric form, so it enters the iron pool, and free porphyrin ring, it is converted into bile pigment, which are bilirubin and biliverdin. So bilirubin and biliverdin are the two bile pigments, and the color of bile pigment is due to these pigments. Site of formation, as already said, it is bone marrow, spleen and liver. Nearly 6 grams of hemoglobin is degraded every day, and 1 gram of heme yields 35 milligram of bilirubin. So daily excretion is about 250 to 350 milligram of bile pigments in the form of bile pigments. So this takes place mainly in the microsomal fraction of the cell. Heme oxygenase is a complex enzyme system, and this complex enzyme system, it requires molecular oxygen and NADPH as reducing substance, and heme promotes the activity of this enzyme. Now we will see the steps. Heme, in the presence of this heme oxygenase, which is a complex enzyme system, in the presence of molecular oxygen and with the help of NADPH, there is breakage of this bridge, that is methine bridge, in between the pyrrole ring 1 and 2. So iron is released, and it is the only reaction in our body where endogenous carbon monoxide is formed. So it is converted into linear structure that is called as biliverdin, and this biliverdin is excreted in birds and excreta of birds and amphibia, and in human being it is converted into bilirubin with the help of biliverdin reductase enzyme. It is also a NADPH dependent enzyme. Aged RBCs, hemoglobin is released, so globin is reutilized. Now this heme, in the presence of heme oxygenase, it is converted into biliverdin, and this biliverdin in the presence of biliverdin reductase enzyme, it is converted into bilirubin. Now this bilirubin is sparingly soluble in plasma. So it needs to be transported with the help of albumin. So and albumin has got two binding sites, that is high affinity binding site and low affinity binding site. And this albumin can, bilirubin can bind tightly with that of high affinity binding site of albumin up to about 25 milligram of bilirubin. So bilirubin albumin complex, it is transported to the liver, and in the liver at the this albumin gets detached from the, this is also called as unconjugated bilirubin, and this albumin gets detached from the bilirubin. At the sinusoidal surface, it is uptake, the liver there is uptake of the bilirubin by the liver, and it is carrier mediated transport, also facilitative diffusion. And this diffusion, this transporter has got high capacity. Means even in pathological condition, there is normal, the excessive bilirubin will be uptake by the liver. So this transport has got high capacity. And in the liver, there is presence of two proteins, that is ligandin and protein Y. And this ligandin and protein Y keeps the bilirubin in the solubilized form, and also it prevents the backflow of the bilirubin to the blood. Now this unconjugated bilirubin, which is sparingly soluble in plasma, it needs to be converted into its non-toxic form, water soluble form, that is conjugated form. So the conjugation process takes place in the liver with the help of this bilirubin glucuronil transferase enzyme. And the bilirubin is converted with the help of 2-UDP glucuronate. It is converted into bilirubin diglucuronide. This bilirubin diglucuronide is also called as conjugated bilirubin. So first there is uptake of bilirubin at the sinusoidal surface of the liver, and there will be conjugation process where unconjugated bilirubin is converted into conjugated bilirubin, and this conjugated bilirubin is secreted now into the intestine, and this is the only step in whole bilirubin catabolism, which is rate limiting step, which is active process, and it is done with the help of multi-organ anion transporter. And there is one protein, that is multi-resistant protein, multi-drug resistant protein 2. If it is deficient, the patient suffers from Dubin-Johnson syndrome. And if this enzyme is deficient, the patient will suffer from Crigler-Najjar syndrome type 1 and type 2. And if uptake is defective, the patient suffers from Gilbert syndrome. So now there is secretion, which is the active process. It is the only step in bilirubin metabolism which is rate limiting step. So bilirubin, conjugated bilirubin now through bile, it enters the intestine. Now in the ileum and colon, in the presence of microsomal enzymes like beta glucuronidase, this glucuronic acid is separated from bilirubin. Now the bilirubin is converted into urobilinogen, and about 90% of urobilinogen, it is converted into stercobilinogen, and stercobilinogen is converted into stercobilin, and this stercobilin is excreted through the feces. And some urobilinogen enters the enterohepatic circulation. It is also brought to the kidney, where it is converted into urobilin, and urobilin is excreted to through urine. So the characteristic color of urine is because of urobilin. Now these are the steps you have already seen. Uptake of bilirubin, conjugation of bilirubin, and secretion of bilirubin, only rate limiting step with the help of that multi-organ anion transporter. This is the lysis. Bilirubin is formed. Bilirubin albumin complex brought to the liver. Bilirubin diglucuronide is formed, that is conjugated bilirubin, and through the bile duct, through bile, it is secreted into the small intestine. It is the only rate limiting step. In the ileum and colon, it is converted into urobilinogen. Urobilinogen enters the enterohepatic circulation. Some is to the kidney and some is converted into stercobilinogen. So what is the difference between pre-bilirubin, or also which is called as unconjugated bilirubin, and conjugated bilirubin? In water it is insoluble, conjugated bilirubin is soluble. While in alcohol both are soluble. This is the normal plasma level. In bile, naturally unconjugated bilirubin will be absent, conjugated bilirubin will be present. And absorption from GIT, unconjugated bilirubin is absorbed, it is not absorbed. Then Vandenberg's test, it is indirect positive, unconjugated bilirubin will give indirect Vandenberg test positive, while conjugated bilirubin will give direct Vandenberg's test positive. That's why conjugated bilirubin is also called as direct bilirubin, and unconjugated bilirubin is also called as indirect bilirubin. These names are based on the Vandenberg's test. Transport we have already seen, one high affinity and low affinity site. Only 25 up to about 25 milligram of bilirubin can bind tightly with that of albumin, and if it increases above that level, the unconjugated bilirubin will cross the blood-brain barrier. So in newborn, the baby will suffer from kernicterus. So this is the last fate of bilirubin, that is, it is converted into urobilinobin and stercobilin. Now, normal plasma bilirubin level, it ranges from 0.2 to 0.8 milligram per dl. Unconjugated bilirubin, it is about 0.2 to 0.6. If the plasma bilirubin level increases above 1 milligram per dl, it is called as hyperbilirubinemia. And if the level is between 1 to 2, it is indicative of latent jaundice. So what is jaundice? When it appears, what is jaundice basically? It is the clinical condition which is characterized by yellowish discoloration of sclera, conjunctiva and skin. And why in conjunctiva? Because conjunctiva is already white in color, and because of its high elastin content, bilirubin gets deposited there. And the jaundice will appear only when the level of bilirubin is above 2.5 milligram to 3 milligram per dl. So what is hyperbilirubinemia? When the bilirubin level increases above 1 milligram per dl. And what is jaundice basically? It is a clinical condition. It only appears when yellow discoloration only appears when the level goes above 2.5 to 3 milligram per dl. So this is the normal range. Total bilirubin 0.2 to 1 milligram. Direct, which is also conjugated, is also called as direct. It is 0.1 to 0.4. Indirect, it is 0.2 to 0.7. Now there are three types of jaundice: hemolytic jaundice, obstructive jaundice and hepatocellular jaundice. Hemolytic jaundice, when there is excessive hemolysis of RBCs. there will be the unconjugated bilirubin will be raised. And the causes of hemolytic jaundice, which is also called as prehepatic jaundice, is the presence of abnormal hemoglobins, that is hemoglobinopathies, that is sickle cell anemia, thalassemia. Then various enzyme deficiencies like G6PD deficiency, where there is excessive hemolysis whenever the patient is subjected to oxidant drugs, and various autoimmune hemolytic anemias. Then in obstructive jaundice, that is post-hepatic jaundice, there is increase in the conjugated or direct bilirubin. And this obstructive jaundice is because of the different the stones present in the gallbladder and carcinoma head of pancreas. Then third type, that is hepatocellular or hepatic jaundice. Commonest cause of hepatic jaundice is viral hepatitis. And liver cirrhosis, alcoholic liver disease, then toxicity to the liver because of various drugs. So in this type, both the types of bilirubin, that is unconjugated as well as conjugated bilirubin, will be raised. You can see here, there is yellowish discoloration of the eyes. Now, how to differentiate between these three types of jaundice? So, hemolytic jaundice causes already mentioned, that hemolytic anemia, different hemolytic anemias like with the patients from sickle cell anemia, thalassemia, there will be increase in the unconjugated bilirubin. In hepatocellular jaundice, which is also hepatic jaundice, there will be both increase in the conjugated and unconjugated bilirubin will be increased. While in obstructive jaundice, only one type, that is conjugated bilirubin, will be increased. In the urine, the urobilinogen will be present in case of hemolytic jaundice, while pigment will be absent, that is bilirubin pigment will be absent in urine. But in hepatocellular jaundice, both urobilinogen as well as bilirubin pigment will be present, because both the types, that is conjugated as well as unconjugated bilirubin level, are increased. While in obstructive jaundice, urobilinogen will be absent, while there will be presence of bilirubin in the urine. So in the stool, the color of stool will be normal in case of hemolytic jaundice. Stercobilinogen will be increased because excessive unconjugated bilirubin will enter the liver, conjugated bilirubin, then excessive urobilinogen and stercobilinogen will be formed. So it will be present in the urine and stercobilinogen will be present in the stool. In hepatocellular jaundice, color may be normal. It is normal, and stercobilinogen may be present or may be absent. In obstructive jaundice, clay colored stool is there, because stercobilinogen is absent because of obstruction. The conjugated bilirubin will not be secreted into the intestine. So there will be no formation of urobilinogen and no formation of stercobilinogen. The characteristic feature of this is presence of bilirubin in the urine and presence of bile salts. Presence of bile salts and bilirubin pigment in the urine is the characteristic feature of obstructive jaundice. Then Van den Bosch's test. It is in hemolytic jaundice, it is indirect positive. Hepatocellular jaundice, it is said to be biphasic. And while in obstructive jaundice, it is direct. While enzyme levels are increased, ALT is normal in hemolytic jaundice. In hepatocellular jaundice, it is increased. while in obstructive jaundice, as compared to this ALP, that is alkaline phosphatase, and SGOT will be increased more as compared to this ALT. While alkaline phosphatase level will be normal in hemolytic as well as hepatocellular jaundice, while be increased in obstructive jaundice. So, in hemolytic jaundice, unconjugated bilirubin is increased. Bilirubin, urobilinogen is present in urine. Bilirubin pigment is absent. While in hepatocellular jaundice, both the types are increased. Both the types of bilirubin are increased. While in urine, both urobilinogen as well as bilirubin pigment is there in the urine. While in obstructive jaundice, only conjugated bilirubin is increased and bilirubin pigment will be there in the urine. So how to differentiate between hepatocellular and obstructive jaundice is that there will be presence of bile salts along with the bile pigment in case of obstructive jaundice. Also, alkaline phosphatase will be raised in obstructive jaundice. Now first we'll see, you can see here, hemolytic or prehepatic jaundice, excessive hemolysis. Then hepatic jaundice, if there is any defect in the liver or if the patient suffers from viral hepatitis or toxins, when the patients are exposed to various toxins, drugs, and post-hepatic is also called as obstructive jaundice. Then first we'll see physiological jaundice of newborn. There is excessive increase in the hemolysis, and as the system which conjugates the unconjugated bilirubin is immature hepatic system for uptake, conjugation and secretion of bilirubin. That's why there is physiological jaundice. It usually appears on the 3rd day of life, usually goes up to 5 milligram. But if it is increased more than that, up to 10, then the treatment should be given. And also the second cause of physiological jaundice is UDP glucuronidase transferase enzyme is also low. This is mostly seen in case of premature infants. And so there is limitation in availability of substrate for UDP glucuronic acid for conjugation. So this leads to naturally unconjugated hyperbilirubinemia. As already told that only up to 25 milligram per dl can bind tightly with that of high affinity site of the albumin. If the level goes above 25 milligram per dl, it can cross the blood-brain barrier, and so there will be permanent damage of the brain. So this is hepatic, this leads to toxic encephalopathy. This is also called as kernicterus. So the baby will be mentally retarded. So bilirubin estimation is considered as emergency investigation. Now the treatment given is phenobarbital is administered. Phototherapy, blue light is given. Here, what is the role of phototherapy? Phototherapy converts the toxic unconjugated bilirubin into easily excretable form. That is its isomers, that is lumibilirubin, which can be easily excreted through the urine. So the baby is kept in the blue light. Now various types of genetic, because of some mutations in the genes, there are different types of hyperbilirubinemia. So unconjugated hyperbilirubinemia, first in this type is Crigler-Najjar syndrome type 1. In this, bilirubin glucuronidase transferase activity is nil, that is, it is completely deficient. Okay. So, and here within first 24 hours of life only, there will be increase in the bilirubin level. So, there will be no response to the phenobarbital, but phototherapy is effective. Though the phototherapy is effective, but it is a fatal disease and the death of the baby occurs within first few 15 months of his life. Then Crigler-Najjar syndrome type 2. There is partial deficiency or of the UDP glucuronil transferase enzyme, and the baby usually responds to the treatment with phenobarbital and of course with the phototherapy. Then third one is Gilbert syndrome. In this, there is defect in the uptake of the bilirubin. There is defect in the uptake of the bilirubin. So the patient will be suffering from that unconjugated hyperbilirubinemia. Then some genetic mutations which causes conjugated hyperbilirubinemia are, first one in this is Dubin-Johnson syndrome, and this MRP2 gene, that is multi-drug resistant protein 2 gene, which is involved in the secretion of conjugated bilirubin into the intestine, which was a rate limiting step. If it is defective, then the patient suffers from this Dubin-Johnson syndrome, which is also called as black liver disease and which is autosomal recessive trait. So Dubin-Johnson syndrome is also called as black liver jaundice. Then last one in this is Rotas syndrome. This is due to abnormality in the hepatic storage, but there is no staining. What is the difference between these two is? This is black liver disease, but in Rotas syndrome, it is again a secretion defect, that is abnormality in hepatic storage defect, but there is no staining of the liver. It is also autosomal recessive condition. Most of the times the patients are asymptomatic here. Now the breast milk jaundice. If the jaundice is prolonged, this may be because of high levels of estrogen derivatives in the maternal blood, which will be excreted through the milk. This will also inhibit the glucuronil transferase system. Also, sulfa drugs, which releases the sulfa drugs, various aspirin, which releases the bilirubin from the high binding site of the albumin, should be avoided in such type of babies. So, sulfa drugs and aspirin should be avoided in the babies. So, it may cause jaundice in the newborn. So, lab diagnosis of the bilirubin, Van den Bosch's test, already shown that in hemolytic type of jaundice, it is direct positive. In hepatic jaundice, it is biphasic, while in obstructive jaundice, it is direct positive. So what is that? It is a specific reaction to identify increase in serum in bilirubin. Principle, it is diazotized sulfonylic acid when reacts with the bilirubin to form purple colored azobilirubin. And so if the bilirubin reacts directly, this is called as, this is given by the conjugated bilirubin. So in conjugated hyperbilirubinemia, Van den Bosch's test is direct positive. But if it is unconjugated hyperbilirubinemia, there should be the addition of some accelerator like caffeine or methanol into the test, which will solubilize this unconjugated bilirubin, and now bilirubin will give the test positive. That is Van den Bosch's reaction. So it is called as indirect positive. While in case of hepatic jaundice or hepatocellular jaundice, as both the types of bilirubin are increased, that is conjugated and unconjugated, it is biphasic. That is, it gives direct as well as indirect bilirubin positive. You can see here direct positive, indirect positive, and biphasic, where unconjugated and conjugated bilirubin is high, gives direct positive reaction, and this color is intensified with the help of, by the addition of methanol, which is indirect positive.